We welcome you all to the fourth episode of OrthoXpert Series brought to you by Centrum Joints. Today we have a new expert speaker, Dr. Rufus Vasanth Raj. He is a senior orthopedic surgeon with over 20 years of experience in the medical field. He has done multiple fellowships. However, I would like to point out that his fellowships are done from very highly reputed places like Ganga Hospital and Ortho 1 for arthroscopy and arthroplasty. He has also done a special fellowship in complex trauma from China, and he is one of the few surgeons who does hip arthroscopy in India. He has completed multiple fellowships in arthroscopy and arthroplasty from Australia, France, and Singapore, and has a special training in something called as nanoscopy or needlescopy from Germany. So he's a widely claimed expert in arthroplasty, arthroscopy, and sports medicine. With this, I hand over the proceedings to Dr. Rufus, who's going to talk about medical management of knee pain.
Hi, good evening. This is Dr. Rufus. I hope you can see the slides. So I'm going to talk about a very open topic, basically knee pain at different age groups. If we see at every age group, patients do complain of some amount of knee pain, but the diagnosis varies in every age group. At any age, one common thing is that you can have fractures. That is, around the knee, you have few bones, patella, distal femur, proximal tibia, or proximal fibula. Most of the times, proximal fibula is treated conservatively. In younger people, smaller children, most of the times fractures are treated conservatively unless there's a specific reason or indication. So if you look at patella, we know that patella can be fractured by multiple variations. It can be an undisplaced fracture, which is usually conservative, sometimes fixed to prevent the movement. Transverse, lower pole, upper pole, vertical, coming displaced, all those things. A gold standard of patella fixation is something called as a tension band winding. I'm trying to keep the slides as basic as possible so that the regular patients and regular people also do understand. So tension band winding is basically you try to fix the part of the bone which is fractured. And this is fixation with the help of screws. And now with the recent advancements, we start using cerclage with the help of fiber tapes or tapes, and also more fancier plates, which are low profile plates. So patella is one bone which can be fractured. Most of the times it's a direct injury or sometimes the aggressive pull of the quadriceps. The other part around the knee is the distal femur, that is the lower part of the thigh. It can be fractured in multiple variations. And depending on the fracture type, different types of fixations like plate fixations and nails can be used. The other part is the proximal tibia or the upper part of your leg bone. So it can be a low energy or a high injury, and usually the classification is Schatzker. And for basic on the, depending on the fracture pattern, we do fixation. Sometimes you do require a posterior medial plating also, that is a dual plating. Now I'll try more into the specific topic. So when we look at kids and teens, when they come off knee pains, excluding the fractures, what are the other common reasons? The common things are Osgood-Schlatter disease, Sinding-Larsen-Johansson syndrome, septic arthritis, something which is very important, it cannot be missed, patellar dislocation, and they can have a discoid meniscus. So if you look at Osgood-Schlatter or a sliding Johansson syndrome, basically Osgood-Schlatter involves the lower part of the patellar tendon, and Sinding-Larsen-Johansson involves the upper part of the patellar tendon. Most of the things are treated conservatively with rest, ice packs, some medications, some braces, all those things usually help. In children, most of the times it doesn't require any major interventions. The other common thing which you should be very, very clear is that septic arthritis, because septic arthritis in children can be a devastating complication. Because if they develop an arthritis, septic sepsis, and if you're not going to treat it, they can have a very bad cartilage or a knee damage. So most of the times what I do is that if suspected septic arthritis, always give an arthroscopic lavage, a nice wash with some antibiotics and other things. It usually works very well. The only key here is that diagnosis. Most of the times it's missed. People would just think that, okay, some knee pain, some knee swelling. If they come little bit late also, it can have a lot of damage inside the knee. That can be a permanent damage in your child's life. The other common thing is patellar dislocation. It usually happens when the medial side structures are torn. You have a medial patellar retinaculum or the MPFL, medial patellofemoral ligament. When it's torn, it gets dislocated. Irrespective of the age, most of the times it's better to repair it. This picture shows a more of a reconstruction. This is one technique where you have two limbs on the patella fixed with the bioabsorbable implants and one limb on the femur. It usually goes on the Shortall's point. So Shortall's point is something which you can read about it. It's specific point which connects looking at the Blue Man Sath line, other factors, we do have some indicators and some scales to measure it also. So this is a MPFL reconstruction done commonly for medial patellofemoral ligament reconstruction for a patellar dislocation. The other common thing is that, which is usually missed, is that sometimes patients will have knee pain, especially kids and teens. While flexing, you will hear something called as a thud. It is not a click sound, it's a thud. So basically, a normal meniscus has a beautiful C-shaped structure. Discoid meniscus is more of a kidney-shaped or a O-shaped structure. So arthroscopically, we normally go inside and cut it or balance it and make it get back its normal shape of the meniscus. So people always think that discoid meniscus are symptomatic, but in my experience, I felt that not all discoid meniscus are symptomatic. Usually they become symptomatic when they have a tear. So discoid meniscus are more prone for injuries and it's more common on the lateral side. When you're coming to the young adults, usually the conditions are a little bit different. They can have something called as a chondromalacia patella. So chondromalacia patella is basically the articular cartilage or the smooth gliding surface on the patella, which usually glides on the femur, is going for a wear and tear. Meniscus tears are very common, ligament injuries, OCDs and osteoarthritis properly. So I'm going to discuss about it in a superficial manner. So if you look at a normal knee joint, the behind the patella, basically the patellar kneecap articulates with the femur thigh bone. So if you start developing wear and tear of the cartilage, it's called as a chondromalacia patella. Early stages, medication and physiotherapy work. Physiotherapy is basically doing some chondromalacia patella related exercises. You can give some knee braces or knee socks kind of a thing with a gel foam around the kneecap, which works well. Medications, if you look at it, there's only one thing which is currently recommended is the type 2 collagen. All those glucosamine sulfate, diacerins are not currently recommended. Type 2 collagens can be given for a minimum of 3 to 6 months. When we go for advanced stages, then we go for something called as a stem cell therapy. Stem cell therapy per se is a bigger topic. I'll be covering in the next few slides. The other option is an arthroscopy, which also I'll explain in the next few slides. And coming to the most important topic of the knee joint for a young adult, most of the times they might have a meniscus tear. See, meniscus is nothing but a fibrocartilage. It is a shock absorber, like how you have a shock absorber in a bike or car. God has given you shock absorbers inside the knee. So the entire body weight, the thigh bone, the big weight falls on the knee, and these shock absorbers take the shock. So when they are torn, they usually have symptoms. Usual symptom is pain. The pain is minimal, but the pain doesn't go off. It keeps on protruding and keeps on happening. Sometimes you might have a asymptomatic phase, and then again the pain will come. Every time the pain again comes, it means that it's tearing more. One meniscus which is very symptomatic is usually the bucket handle tear, as you see in the picture, the second row, last picture on the right side. So it looks like a handle of a bucket. So this usually flips into the joint. So many patients complain of locking. The common complaints of meniscus are pain and clicking, but bucket handle tears do have locking episodes also. Their knee gets stuck in a particular position and then slowly extends or extends with a movement. So meniscus, as far as is concerned, all meniscus should be repaired if possible. The old concept of white zone, white red zone, and red zone, people used to believe that white zone need not be repaired, but the current recommendation is that even white zone has to be repaired because it has still got a 50% healing potential. So you can't take chances on it. And all meniscus has to be repaired. Usually, if you look at a meniscus, if you look at the second picture, you have a posterior horn, body, and a anterior horn. So usually the posterior horn and the body can be repaired by all inside technique and inside out technique, but the anterior horn usually is better repaired by an outside in technique. So the other important structures in the knee are the four main ligaments: ACL, PCL, MCL, LCL. ACL, PCL are more of intra-articular structures. If you see in the picture, ACL is in the front and PCL in the back. MCL is on the medial side, that is the inner side of the thigh, and LCL is on the outer side of the thigh. So all these ligaments can get injured, out of which commonly injured ligament is ACL. This is the picture on the left is the ACL reconstruction, and on the right is the PCL reconstruction. Nowadays, there are multiple techniques on it. The picture which I've showed is something which I do it, ACL reconstruction, which is fixed on the top with a small button. It can be, depending on the company, it's tightrope or endo button, alter button, whatever name we use. So button, the mark C structure is the button. And inside you have a graft and it can be fixed on the lower side with whatever you do. This is an all inside reconstruction. So in all inside reconstruction, I take only the semitendinosus. It is usually quadrupled and it's very strong. It usually gives a minimum 8 mm thickness. And on the lower side, we fix it with a button. Initially, we used to fix the smaller buttons, and nowadays a bigger button like an ABS button is preferred. And if you closely look, this technique involves a fiber tape or a tape in front of the graft. So this comes out separately and is fixed at extension with the help of a structure, that is a bioabsorbable civil lock anchor. So basically, it's like a seat belt technique. So your ACL graft is fixed at 30 degree of flexion, but this extra protection on the front is fixed in extension so that it gives more protection. So this is something which I do regularly for high demand athletes and obese patients. Regular patients can just survive with the regular graft with a button and maybe a bioabsorbable screw at the bottom. But when you encounter higher demand patients and obese patients, I always feel better giving them more support. On the right side picture is a PCL reconstruction. It can be done on both sides with the screws, or it can be done the same way like ACL reconstruction. MCL, LCLs are usually repaired. Most of the times you have to give the benefit of doubt. They heal by themselves by 3 to 6 weeks. But you can also do an internal bracing. So internal bracing is like how you have an external brace. You can put an internal tape fixed with civil lock anchors. So these give you extra additional support. Another important topic is that many times missed also. There's something called as an OCD, osteochondritis dissecans. It's a lesion or it can be a cartilage defect following an injury. So OCD lesions, when they are acute and then they're very clear, you go inside arthroscopically, see the lesion and fix it. The first picture is actually doing retrograde drilling to increase the blood supply. And the lower bottom picture is like it can be fixed with bioabsorbable small pin kind of structures, biopins. So this is something which is very, very useful. When they come in an early stage, acute injuries, always try to fix it. If they come a little bit later stage where the cartilage is gone and become a big loose body, you have to remove the part of the cartilage. You can do something called as an oats. Basically, you take punched out cartilage from the non-weight bearing zones and then fix it in the defect. There are multiple other cartilage related procedures also. Now we have more advancements. We have systems where you can put fibrin glues. We can take some cartilage, mosselize it and then put it back. We can now BMAC has also changed as more of a mosselized graft. So all these advancements do help us in tackling cartilage injuries because I'm talking about younger adults. In younger adults, when they have a cartilage injury, it can be devastating because they might end up in a knee replacement at a much earlier stage. So to prevent that, cartilage is very, very important. So these are the various things which are done. Worst situation. For example, I recently operated a young chap, young in the sense he's around 38 years old. He was an active football player with multiple injuries in the knee, but never addressed any meniscus or ligament test. Now he's currently becoming a coach and he's in severe arthritis. So younger people can also develop arthritis. The more common is a post-traumatic arthritis, sometimes rheumatoid arthritis. But rheumatoid arthritis is a different entity. But post-traumatic arthritis, so this is how the grading of arthritis happens. Grade 1 is normal, usually no symptoms and no treatment. Grade 2, you start developing cracks, no changes in the X-ray, or minimal osteophytes can be seen. In grade 3, usually the symptoms are more severe. The joint space narrows in the X-ray. And grade 4, usually it's bad. The bone-on-bone conditions are usually grade 4. So when we see younger adults, I would be still very skeptical of doing a knee replacement. If possible, always the first choice is a high tibial osteotomy. Basically, you cut on the proximal tibia. The commonly done is a medial open wedge osteotomy. You open it up, put it a little bit into a valgus kind of a thing, and then fix it with screws and plates. If necessary, you can use bone grafting. Otherwise, not necessary. Usually, they do very well. So now coming to elderly, when somebody elderly comes to us with a knee pain, usually the only diagnosis or the first diagnosis is a arthritis, but they can also have a meniscus root tear, which is very, very common and commonly missed. Usually, meniscus root tears have a classical injury, a twisting injury, while getting up from the floor or getting down from a bus. They have a very classical symptom. Younger adults usually don't have a root tear. Root tear is more common in older adults. These are the various types of root tears by Laprade, and usually root tears has to be repaired. It's a different technique. You have to drill tunnels, fix it, bring it down and fix it. I fix it with a bioabsorbable implant like the Lock anchor. Some people use just threads. Some people use buttons. But basically, meniscus root tear has to be addressed because this is very aggressive lesion. It moves very fast. And also when meniscus root tears move very fast, you can actually have a problem of very severe arthritis. Sometimes I've seen patients who are 65, even 75, but their knee will be beautiful. There's no arthritis. They'll be very active playing golf, playing tennis, but they'll develop a root tear. In such situations, just an arthroscopic procedure to repair the root is more than enough. There are two studies which say that if you have a varus deformity along with that, this root repairs can be combined with the high tibial osteotomy. They do really well. Now, coming to the osteoarthritis, I've already explained. Normal knee looks beautiful. You have the femur and the tibia, thigh bone, leg bone. You have a nice joint space. But as I said, the arthritis progresses. So the joint space narrows. That is for easier way of identification for non-medicos. In early stages, that is in stage one, which are usually asymptomatic, and stage two, medications and physiotherapy work. So, what kind of medications? This is something which I was already discussing for the chondromalacia patella for the younger adults also. Usually, analgesics give immediate pain relief, but the only problem is that they're short-lived and long-term effects can cause side effects. Now, different kind of coxib drugs have come, like palmocoxib, which they say that you have to give only 2 milligrams, but for a longer duration it works. So, those things can be tried, but generally, analgesics are generally for a shorter duration, especially when patients have an acute exacerbation of OA. Suddenly, be a normal person, suddenly, they'll have a severe pain. In such situations, analgesics usually work well for 5 to 10 days. Type 2 collagen is something which is current recommendation, no immediate effect. It tries to regenerate the cartilage. Be very clear, it tries. There's no guarantee that it can. It tries. Long-term usage are needed and it doesn't have any major side effects, so it can be very casually given for patients. In physiotherapy, there are only two things. One is the pain relief modalities. You can give like IFT, ultrasound, TENS, laser, cold therapy, hot therapy. Temporarily, the pain gets released, but you have to keep doing it every day. I do know patients who are very unwilling for surgeries, and every day they'll be doing physiotherapy. Exercises basically they increase the mobility of the joint and also they strengthen the muscles outside the joint. So the muscles around the joint get strengthened, they take up more load. The load falling on the knee is reduced. So that makes a big difference for people. When you go for the type 3 moderate, that is a little bit higher level of arthritis, physiotherapy and tablets might not have some much effect. They would have already exploited all those treatment options. In such situations, injections and arthroscopic surgery are the next treatment choices. So in injections, you have three kinds of injections which are commonly used. One is steroid, the other one is hyaluronic acid, the third one is stem cell therapy. Steroids, the big advantage is that it's cost effective, immediate pain relief. Patients love steroids. But the problem is that they're very short lasting. It's few days to few weeks. Some patients even say it work for a few years, but it's very rare. But usually few days to few weeks. In fact, some patients can have increased pain also. And when I don't prefer repeating it within 6 months because it really lowers immunity and patients do can have arthritis, sepsis, and personally, more steroid use itself can cause cartilage damage and usually doesn't offer any major cure. Hyaluronic acid is something which came after steroids, a little bit of better advancement in medical field. The big advantage is it's considered more of a lubricant. It usually does a decent pain relief, but it again lasts only for few weeks to few years, few months. If you look at the disadvantages, yes, it's a little bit expensive and doesn't offer any cure, even though they say that multiple usage of hyaluronic acid actually allows the cartilage to grow. It's still a very skeptical statement. So repeated injections might be needed. Some patients even come every month and get injections. Usually they don't have any major side effects. When you come to stem cell therapy, basically the advantage is that this is something was a breakthrough because it tries to offer cure. A steroid doesn't cure you. Hyaluronic acid was not very clear, but this tries to offer you a cure and is a very natural therapy and no artificial agents are added. In fact, even local anesthesia should not be added to stem cell therapy because the stem cells can die. So it's based given as only stem cell or it can be mixed with a lubricant. Disadvantage is yes, it's expensive and there's no immediate pain relief. So this is one thing which we have a big problem because sometimes we give a PRP or ACS or BMAG, whatever we give, patients say nothing happens. It's so expensive. I didn't feel anything. It's not like a steroid. And repeated injections might be needed. So if you look at the stem cell, this is how the spectrum goes. The basic is PRP, which is many studies and many people feel that PRP is not a stem cell. So then comes ACRS, then ADCSC and BMAC. So PRP is basically very simple. You take the patient's blood, 15 to 20 ml, depending on the company you're using, put it in a centrifuge machine. The platelet-rich plasma separates. You're going to inject it back into the knee joint, and the patient is going to walk back home without any pain. ACRS is one step little bit higher. It's not just centrifugation, but you also need to incubate it for around 3 to 4 hours. So if the patient gives blood in the morning, maybe evening they can come back for the injection. It is believed to have more growth factors. Autologous conditioned serum is believed to have more growth factors than the regular platelet-rich plasma PRPs. ADCACs are basically taken from your adipose tissues. It's adipose tissue derived stem cells, ADCAC. It's taken from your abdominal fat, is more like a liposuction, which gives more growth factors. PMAC, as we all know, we take it from the anterior superior or a posterior superior iliac spine. We take it from the syringe and centrifuge it. It usually gives a more higher level of growth factors when compared to any other stem cell therapy. The other option for arthritis is in the grade 3 is arthroscopy. So advantage of arthroscopy is that it's a very keyhole procedure. It's much less time consuming and patients are more mobile after the procedure. So one is called as a radio frequency chondroplasty, RF chondroplasty. So if you look at the A picture, the cartilage wear and tear is very clearly seen. When you use a radio frequency probe, it smoothens out the edges. Most of the times the pains are because of these fibrillations. Once the fibrillation is smoothened out, patients feel really comfortable. The other thing is called as a microfracture chondroplasty. So basically you use an arthroscopic awl. You make small pricks, usually around 3 to 4 millimeter of bridge should be there. It's a 45-degree awl, which is more comfortable. So the blood comes out. Once you stop the tunica and you see the blood flows out, and this stimulates the cartilage growth and a new cartilage is formed. Of course, not a fibrocartilage, not a Haleon kind of cartilage, a different kind of cartilage, but it's very useful. When you go to the stage 4, that is severe arthritis, we have to either go for a knee replacement or a unicondylar, total knee replacement or a unicondylar knee replacement. Very rarely, we actually encounter patients with only one joint arthritis. If you're going to do a unicondylar knee arthroplasty, you need to be very particular that it should be involving only one joint. All the ligaments should be well functional. So there are few restrictions for it. So it's not much famous, but still a lot of surgeons do it. I'm a little bit different, or maybe it's because I do arthroscopy and arthroplasty, because most of the arthroplasty surgeons prefer a unicondylar, but most of the arthroscopy guided surgeons would prefer a high tibial osteotomy over a unicondylar knee replacement at any stage of arthritis if it involves a single compartment. So the other one is a total knee replacement. Basically, total knee replacement is like it has got three components: a femoral component which fits to the femur. You have a polyethylene or a plastic kind of a component in the middle, and a tibial component which goes into the tibia. So it can correct any kind of arthritis. We can have stem options and other options. Basically, a higher level of arthritis treatments requires more implants. The more metal is used, the lesser the life of the metals. Normally, knee replacement very casually comes around 15 to 25 years, depending on the patient. But when you use more metals, the life do come down. So on a conclusion, I would say that every patient in different age group have different kind of problems. So diagnosis is the key. The biggest problem is that most of the times diagnosis is missed. From the patient side also, it's still a practice where patients just go to the nearby pharmacy, get some medicines for pain, or directly go to the physiotherapy and do some physio without knowing what it is. So diagnosis is the key. Always try to establish diagnosis. And earlier the diagnosis, the easier is the treatment. And usually in knee, most of the treatments can be treated, most of the problems can be treated effectively, whether naturally or sometimes it might even end up in a knee replacement, but they all do really well. Thank you.
Yeah, thank you, Dr. Rufus. Can you just stop the screen share?
Yeah, sure.
So it was a highly comprehensive coverage of knee pain, right from a fracture to the arthritis, including all the sports injuries. So I have a few questions from our audience. The first
Yeah, sure.
question is that we'll talk about medical management of osteoarthritis. So
Mm.
we have discussed that you give analgesics and you have there is some recommendation of collagen type 2 also. So I want to know, do you start collagen type 2, say for example type 2 osteoarthritis? Do you
Mm.
start collagen type 2 on day one with the analgesic and then eventually discontinue, or how does it work?
I started with the analgesics because they don't cross react, so you can start it with the analgesic.
And then for how long can we give it safely?
Safely is 3 months. The recommendation is OD dose, 40 milligram of collagens, type 2 collagen, OD dose for minimum 3 months. It can be extended up to 1 year also, but minimum 3 months to start with.
Okay. And when do you start seeing discontinuing any analgesic? After how many days?
Usually, I give analgesics maximum for 5 to 10 days. I always tell the patient that analgesic is not going to be the treatment of choice because most of the times arthritic patients are elderly patients. So loading them with analgesics can have a lot of side effects. Of course, yes, if you can go to kidney-friendly analgesics like paracetamol or tramadol combinations, you can give it for a longer duration of maximum 1 month. But otherwise, analgesics are discontinued after 10 days. The collagen, now I've switched on to palmocoxib. So palmocoxib is a type of a coxib which is only 2 milligram OD dosage, which is supposed to be little bit effect on pain factor. So collagen, along with it, I give it for 3 months. So most of the patients do have some amount of relief with the pain factor. I'm not sure whether the collagen is working or the palmocoxib, but I try to give both together.
Have you found any side effects with collagen?
No.
So
So,
usually it is like a nutraceutical over the counter also you can purchase, but it is
yes,
basically better prescribed by the orthopedic surgeon. The second
yes.
question is about HTO versus UKR.
Hmm.
So when do you do UKR and when do you do HTO?
If you actually see, most of the indications for both of them are almost similar. I think it's purely the surgeon's choice because I feel that most of the arthroplasty surgeons, or for example, I'll tell a funny incident when I first did my joint replacement fellowship in Ganga. So when I did my joint fellowship, I actually presented a publication and I also presented in a national conference. UK was a HTO where I spoke in favor of unicondylar knee. But after one year, when I did an arthroscopy, I actually spoke in favor of HTO. Because somehow in arthroscopy, I started believing it works because if it's my knee, I would still try to do something without changing the knee. So unicondylar knee arthroplasty, when I was with Dr. David Rajan sir in Ortho and Hospital, we have done big follow-ups, like 5 years, 10 years follow-ups. When we do a re-arthroscopic procedure, we see that it beautifully grows. We will be very shocked. I will be very shocked whether it's the same patient. How do the cartilage grow so much? Because high tibial osteotomy works really well. So I do ITP. Any patient whom you say that UK is indicated, I'll do a high tibial osteotomy. But this is a surgeon's choice. I do understand that some surgeons might not accept this view, but I prefer to do it because it's still superior than replacing your knee. So it's very good actually.
So that is actually the right choice, but the issue with sometimes with the working class of patient is that when you do a UKR, you are going back to work in 10 to
Work
15 days
faster,
max.
faster.
But when you're doing
Yes,
HTO, you cannot go back to work for at least 2 months because you
yes,
have been
six
on
weeks
bearing for
minimum.
1.5 months at least.
Yes, yes, yes. That's true. That's true, actually. That I explained to the patient because also when some people, when they have a bad varus and all, SGO, what correction SGO gives, UK can't give.
Right.
So that makes a big difference because not correcting the mechanical deformity, patients do feel unhappy.
So let's talk about something related to STO. So when
Hmm.
you see a root repair in an MRI, sorry, a root tear, medial meniscal root tear in MRI, will you always get a scanogram?
I get a scanogram. Yes. If
Okay.
you actually look at the literature, most of the literature says even if you don't do a root repair, just doing a high tibial osteotomy is enough. Many surgeons who don't know to do an arthroscopy just do a high tibial osteotomy. But I, as an arthroscopic surgeon, always prefer that. See, that is also a mechanical problem. You need to repair it because now the repair of root has gone to different levels. Because root tears always have an extrusion of the meniscus. So we now do put anchors inside the knee joint to put the centralize the meniscus also. So it has gone to the next level. But along with that, if the patient has got a varus deformity or a proper, when I do a scope, if I feel that it's proper arthritis, I always combine it with the high tibial osteotomy. All my root repair cases will have a high tibial osteotomy as back. So it will be inside the operation theater. Of course, yes, I do a scanogram. Why I'm saying this because sometimes in scanogram it looks normal with mild varus, but once I go inside, it'll be like grade 3, almost grade 4 arthritis. So it's very difficult to come out without because we don't know whether the pain was because of arthritis or because of the root tear. So in such situations, I combine it with the high tibial osteotomy.
Okay. So in these type of patients, when you're doing a root repair where you find there is a minimal arthritis and you're doing an ST also, would you like, have you got any experience of injecting hyaluronic acid or any similar type of injection during the surgery, post-operative surgery, what, matlab, after the
Most of the
surgery?
times in arthroscopic surgery, I don't inject anything inside because arthroscopy is done with water. So most of the times it gets dissipated or comes out. Whatever put you put just staples on the scopy portal, so it'll invariably fluid will come out. So I don't prefer it. Any patient who requires an hyaluronic acid or a stem cell therapy, I always tell them I charge that in the insurance, make sure it's covered in the insurance. And when they come for suture removal, I remove the sutures and give the injection.
Okay.
But yes, it can be given.
Okay. So now we come to the TKR part. So the total knee replacement. Is there any age limit where we should not do a total knee replacement and try to salvage the knee?
No age limit. Because again, the places where I've been trained, we have done knee replacements for 21 years old with rheumatoid arthritis also. We've done knee replacements for 95 years old persons who are like very active, who will not look like 95. So the biological age is different. Some patients will look like only 65, but the age will be 75, 85. So as long as my criteria is that any patient who's walking with a good muscle mass, I would be very happy to do a knee replacement. The patients who do really bad are short, obese women and patients who have very bad muscle mass, or they're coming to me saying that last 6 months I'm on a wheelchair. Those patients pathetically they perform. So just replacing the knee might take off the pain, but they will never walk. So patients don't understand. See, that's the reason why many patients come to me and say that no, my relative did a knee replacement to another doctor. They are not walking. I don't want surgery. It's all because the patient selection. Sometimes surgeons try to be aggressive, try to do knee replacement for all patients, but I think the patient selection matters. If I see the patient is not a great candidate for knee replacement, I don't do it. See, because we do face a lot of complications inside operation theaters. Many people even don't know about it. See, I can share. See, the more numbers you do, you start seeing more complications. I've had a patient who was very young, who was only 32 years old, staff nurse with the ACL tear. Just 2 days old ACL tear came to me, walking to me. So we posted it for surgery, posted her for surgery. Inside theater, after spinal anesthesia, she developed a pulmonary embolism. She died actually. So spinal anesthesia gave a vasodilatation. The leg was lifted for tourniquet, the DVT dislodged, and a massive pulmonary embolism. So all these things do matter. So the patient profile is very, very important. So everything, as you gain experience, we realize that it's not just the surgery. Surgery part is very minimal. So age is not a major problem at all. If the patient looks younger by physical activity and they're walking well, I think they deserve a knee replacement if they have a pain in the knee.
Okay, now so a reverse question. Is there an age
Hmm.
limit for ACL reconstruction?
No, the oldest knee ACL reconstruction which I have done is around 68, and which Dr. David Rajan sir did was around 78. So again, if we show you the video of the knee, you will think that's age of a 20 or 30-year-old knee because there won't be any arthritis. A patient who's got no arthritis, just having a ACL, that requires ACL reconstruction. The problem is that our mind is set with age. Age has got nothing to do. It just look at the knee. If the knee is young, it's a ACL reconstruction. That's all. Again, if the knee is very old, very badly arthritic and all, doing ACL reconstruction is the biggest disaster you can do for the patient. It requires a direct knee replacement.
So what I had heard from the literature, or I had read from the literature, is that if there is an ACL tear with an arthritic in an arthritic knee, which is like a grade 3 or 4, that is the perfect indication for doing a knee replacement rather than doing anything else.
Yes, yes. Grade 4 automatically. Once it's a grade 4 knee, irrespective of whether you have a ACL or a meniscus tear, doesn't matter. Grade 3, it's like two-way. If they're a little bit relatively young or less than 60, grade 3, I would still do an arthroscopic procedure, try to stimulate the cartilage, do some cartilage procedures. But if the age is on the higher side, 65 plus especially, grade 3 with the ACL tear, I will directly go for a PKR.
So now I want to come to a more detail about knee replacement. So what approach is your preferred approach for a TKR, a primary simple TKR in a varus knee?
I always do an anteromedial parapatellar approach. In my training, only one thing which anterolateral parapatellar approach. If there's a fixed valgus of more than 30 degree, I do a anterolateral. Otherwise, the straightforward anteromedial parapatellar approach. I'm very comfortable doing it. I don't do all these subvastains and other approaches. It's very straightforward. Most of the times, patients are not worried about cosmetic scars and other things because they are elderly patients. Very rarely, I've encountered some models where they are older, but they still want to have a cosmetic scars. So in such situations, we can do something with the plastic, but I don't try to compromise the skin incision because most of the times we encounter patients who are like obese also. In obesity, it's very difficult to have a minimal incision. You obviously need to have a bigger incision because you're going to go deep, retracting the fat. So I do an anteromedial parapatellar approach. That's what I regularly do.
What about CR versus PS?
I regularly do PS. All the places I've been trained was always PS because I don't find any literature supporting a longevity with CR. PS is relatively more straightforward and more predictable when compared to CR because I also logically feel that most of the elder patients, the cruciate ligaments are not great. So relying on that and balancing might not be a great choice. PS is a perfectly beautiful implant. Most of the surgeons do it, and result-wise, worldwide, PS has got equal results with CR. So I don't find any added advantage of doing a CR.
So in a TKR, we come to the last few questions. In a TKR, there is something called as patient-reported outcomes versus the X-ray. So many times the X-ray looks
Yeah.
fantastic, but the patient still keeps on complaining the pain. One very
Yes.
senior surgeon once told me in one of the conferences that if you do a good hip replacement, patient is going to forget that he has a hip. But a knee
Yes.
replacement patient never forgets that he has a knee. There is some issue or the other which small keeps on popping up sometimes or the other.
Very true, because a perfect X-ray shows only the bones. We don't know what was actually done inside about the balancing of the soft tissues. You might have not balanced it properly. You might have put the knee much tighter. All those factors come into it. One of the commonest mistakes is that people trying to put the knee very tight. Putting the knee very tight is only accepted for rheumatoid because it stretches after the surgery. Otherwise, the biggest mistake is tight knees. So many people, 9 will be looking perfect. They'll try to push an 11 insert. So it will be very tight. So automatically those knees perform very badly. And as I said before, the muscle mass matters a lot. Somebody who's not walking, because arthritis is a very slow process. People adapt. Initial days, they will find it difficult to sit on the floor and get up, then difficult to use Indian toilet, then difficult to climb steps. Whatever is difficult, they will stop it. And they'll convince themselves saying that, no, I'm fine, I'm walking. Because they're walking well, because they stopped everything which was causing pain. So you adapt. So basically, when you stop certain movements around your knee, the thigh muscles and the calf muscles, certain level of activity comes down. There will be some amount of wasting in some planes. So automatically what happens is that they never perform well. So X-ray might look really beautiful. Sometimes it can be the surgeon's problem where the balancing or the handling of soft tissue inside the knee was very bad. Or sometimes even however better we do, still patients complain of paresthesia effect around the knee. Some patients have skin lesions around the knee because of that. Those are one issues. The other thing is that I think the patient's muscle mass and patient's motivation also plays a big role. I try to motivate them. I try my level best to do bilateral because I do it fast. Because after one knee, especially very bad varus knee and all, one knee doing will never work. And patients lose confidence on the surgery after they do one knee. Because, see, it's like bike tire, two tires being worn out and you're replacing one tire and expecting it to run, it will not run. So, patient factor plays a big role.
Do you use tourniquet during your TKRs?
Yes. I
When do you
used to.
release the tourniquet?
I release it only at the end of the procedure. I don't
After the
release it in
closure.
the middle. Yes. There's no correct. That's a very valid question because right now they say you don't need a tourniquet. You can do it on that. Actually, the tourniquet role is only while cementation because blood coming out of the bone is a very bad sign for cement because cement will not set properly, except for cementing. And that too, if you have a good pulse lavage and everything is perfect, even for that you don't need. Except for cementing point, you don't need a tourniquet at all. But I generally do it again, it depends on the surgeon. Some surgeons are very slow, means they're going to do it very slowly, very meticulously. Those surgeons will take longer time. They obviously can't have tourniquet. If you're going to do the surgery in half an hour to 45 minutes, like what I do, then most of the times it's beautiful, nice. I put the tourniquet, I nicely put a crab bandage and finally release the tourniquet. Or you have to release the tourniquet and catch all the bleeders. That's also fair enough.
Do you use a drain?
I use a drain.
And how many days do you keep the drain on?
Usually, same concept, 2 days. I'll see on the first day if it's very less, then I'll remove it off. On second day,
Okay.
I've not encountered the infection because of drains. It's very rare actually.
What about the
Some people put
post-op rehab?
the earlier the patient walks, the more confident they are, the more better it is. The places where I was trained, we used to give a rector canal block so that the patient femoral block can make the knee buckle. So a rector canal block, and day one we'll try to make them walk. They feel very happy. I don't prefer giving epidurals because whatever we say, sometimes epidurals can have its own side effects and patients are not comfortable. Sometimes it becomes very numb. Even though we try to give only a sensory block also, it doesn't work sometimes. So I would always prefer a rector canal block, or even if nothing is given, because I don't normally infiltrate the posterior capsule because I felt it gives mixed results. Infiltrating posterior capsule, some patients feel very happy, some patients didn't feel any big difference, but a block really works. So I try to mobilize them as early as possible. I would like them to use walker for the first few days, depending on the patient profile. Sometimes they have used for 2 weeks also. Otherwise, first few days. First day is mainly walking, going to restroom, sitting and getting up. Second day, train them to climb up steps, and I discharge them on second day.
You discharge them on second day. Do you, if you're putting a drain, then you have to remove the drain, and do you do the dressing or you just remove the drain?
No, I do the dressing. In
Okay.
fact, I remove the drain and drain part. If it's not bleeding much, I put a nice waterproof dressing everywhere and ask them to take bath.
Okay. I think that's all for today. Just one last question has come up. What about post-operative nutrition? Like, do you give protein supplementation? Do you give multivitamins like Centrum or something like that post-operative to the patient?
I actually give Usually, what I do is that till suture removal for the first 10 days, I do keep them with some mild analgesics. I'm not a big fan of giving antibiotics, but sometimes, yes, when you do in different kind of hospitals, when you're not very confident, you try to give. It's just for your feeling better, but I don't know whether it's really proved or not. Otherwise, I give analgesics for the first few days till we remove the stitches, around 7 to 10 days. Once the stitches are removed, I do give them supplements. I feel it makes a difference. Patients also feel very happy because somehow their food habits come down because their mobility is less. So I somehow feel they don't eat well. So I do give protein powders. There are orthopedic protein supplements also, and some Centrum, all these kind of multivitamins. They do make a difference.
Okay. Thank you very much. Thank you, Dr. Rufus, for such a nice discussion and a comprehensive coverage of knee pain. We thank Dr. Rufus for taking out his time and spending time with us and discussing knee pain in detail. We thank our viewers as always to be there with us and have a good night. Thank you.
Good night. Thank you.
Rishi, you can stop.